But we're going to start off, and I'm going to talk a little bit about, to start, mild, moderate, and severe brain injuries and ways to differentiate those. Then I'm going to get an overview of PTSD, going through the diagnostic criteria. I'm going to talk a little bit about overlapping symptoms of PTSD and TBI. I think that's twofold when we talk about PTSD and TBI. One of them is the co-occurring symptoms or overlap when we talk about mild TBI and PTSD. The other would be, can PTSD happen or occur after a severe TBI? So I'm going to talk a little bit about that. So we'll just kind of go through, in terms of questions, I prefer to wait to the end just so that we can kind of get through it. I don't know if anyone has paper, write the questions down. If I need to come back to something, I will, to clarify. With that, let's delve into this. So in terms of brain injury, I'm going to start with some statistics. An estimated 1.7 million people sustain a TBI in the United States annually. There's, it's between 1.5 million and 2 million actually, so 1.7 million, which is roughly the size of the population of West Virginia, to put that in perspective. In addition to that, when you compare that to other occurrences, like with breast cancer, it's 212,000, lung cancer is 200,000, and HIV is 50,000. So there's a lot of people sustaining a TBI. Now, this is a range of TBI, so we're talking about mild, moderate, and severe. Of those, 52,000 individuals die, 275,000 are hospitalized, and 1.365 million, which is nearly 80%, are treated and released. And so what does that mean? Majority of those are mild. If you're not getting hospitalized, it's more than likely mild. They're sending you home to rest. It's good news that only 52,000 are dying. That means medical advances have improved over time, and there's a low death rate, which means those that are surviving these severe injuries are going to need support and understanding over time. TBI is a contributing factor to a third of all injury-related deaths in the United States. So it's significant. This graph right here, if you look at it, it just shows who is getting hospitalized and the age of the occurrence. So we're seeing an increase in TBI from age 0 to 4, and anyone over 65, and that's in relation to the type of injuries that are occurring, and I'll talk a bit about that. Then you see a spike kind of in the middle there in your 20s, when that frontal lobe is getting fully developed. And that's the rate. The top line there is emergency department visits. The middle line there is hospitalizations, and that bottom line is deaths. So majority of people are surviving, and majority of them are mild. So this gets us into types of brain injuries. Majority of brain injuries are due to falls. So that's related to children and elderly over 75. That's where we see that spike, which makes sense. You got children running around learning to walk, they fall, and then you have elderly trying to maintain their balance at times, and they may fall. The next one is struck by or against, so getting hit, motor vehicle accidents, and then assault. The really interesting thing about this graph, if you look at motor vehicle accidents, you see a spike in the age range of in the 20s to 30s. Again, that's where your frontal lobe is developing, and you may have some more risky decision making and not listening to that inner voice to tell you to stop. So, and what we know is that in terms of frontal lobe development, that's our area of our brain that is decision making, and it doesn't develop fully until around 26. So, if you look back at your life, you may have made more riskier decisions 18, 19, 20 years old. Because I do work at the VA, I have some information on military service members. This graph, shows different areas of military service and who's getting more TBIs. What we know is Army and Marines are up there, and then following below is Air Force and Navy. So what does that mean? They're out there on the front lines getting more exposed to blasts and things like that, so they're more at risk for that. And speaking of blasts are one of the top reasons that TBI occurs within the military population. And as of 2010, 60% of patients seen at Walter Reed had blast-related injuries and have sustained a TBI. And then in the VA, what we're seeing is people coming back and been exposed to blast, and that's categorized as a closed head injury. And I'm going to talk a little bit more about types of head injuries here in a moment. But majority of them are mild TBIs. So, all right. In terms of traumatic brain injury, it's caused by a bump, blow, or jolt to the head that disrupts the normal function of the brain. Other people define it as alteration in brain function, brain pathology, things like that. There's closed versus open TBI. So closed TBI, that's when there's not an the skull doesn't have an opening and it hasn't been penetrated. And open is where you would see an actual wound. So there can be external forces that cause head injury, the head being struck by an object. You have the counter-coup motion, which is what we're seeing in that picture. It's a rapid acceleration and deceleration of the brain. So your brain's getting rattled very quickly. So a foreign body penetrating the brain, or forces generated from events such as a blast or explosion. There's also acquired brain injuries that are separate from things that happen due to congenital defects or degenerative disease. So that can be things such as stroke or brain aneurysm, brain tumors, hypoxia. It's when there's minimal level of oxygen to the brain. Anoxic brain injury, that's where there's no oxygen going to the brain and the cells in the brain are damaged. Toxic or metabolic injury, infection, alcohol and drug abuse. So one of the things I will say, it's not just alcohol and drug abuse. I've worked with a population of people that have tried to become sober, and to do that they have decided to go off drugs and alcohol at home alone and suffered a brain injury, and a severe brain injury at that. So that can even be risky when you're talking about alcohol use. It's trying to get sober and doing that independent of others. This is a severity rating for TBI. So I'm going to go through each of those things separately because those are the things we look at when we're categorizing TBI. There's going to be a range. It goes from mild to severe, and the more severe, you're going to be unconscious or have more impairments. What I want you to keep in mind when I say mild TBI, that is a concussion. I don't know if all of you are aware of that, but that is the case, and we'll talk about that more. So the first section on there, the GCS, is the Glasgow Coma Scale. That is a measure used in the hospital typically, and you see this in charts and reviews. So when people come in and you're getting this information, it's already occurred, usually, and especially within polytrauma, we're asking the questions. Either they know it or their significant other knows it, or we've read it in a chart based on history. But when you're hospitalized with a brain injury, they measure your Coma Scale, and 13 to 15 means you're following commands and you're able to engage. So that would be a very mild TBI. If you're completely unconscious and not non-responsive, that would be a more severe injury at the time. And, you know, you would get likely hospitalized for that, and hopefully those scores increase as you came more out of that coma. Alterations of consciousness, AOC. Following a TBI, an individual may be rendered unconscious, may be confused or disoriented, mentally dazed, have difficulty following commands, things like that. You know, you have to look at duration of this, so that it may be present, but it doesn't mean it's going to be a severe or permanent damage to the brain. One of the important things is that later, when questioned about this period, they may recall events from the accident forward. So they still recall events, even though they were confused at the time. So then there's loss of consciousness. So how long were you out? And what was that time duration? And that means unresponsive or in a coma. And, you know, this is not the tell-all of how severe the brain injury is by any means. And it seems easy, but it's all muddled in there based on other factors. So because the injury may be unwitnessed, you have to go on what they recall, what they've been told, and things like that. Especially with the military population, they may be exposed to a blast and not know how long they were out, one, and then two, they just got up and started working again, even when they were experiencing an alteration in consciousness. Dizziness may be present, they're kind of confused, but they, you know, they're trained to go out there and survive. So you're gonna, it's hard to get these measurements at times. But the greater duration of loss of consciousness equals a more severe TBI. So post-traumatic amnesia, PTA, it's the time interval from when a person regains consciousness until he or she is able to consistently form memories. So basically, you know, a person can be awake, functioning, following commands, but once distracted, they won't remember that interaction with you. They don't remember what you talked about or what you did. And that period of time is not a time where we're going to offer treatment. You just keep that person safe, because there's no point in engaging in a therapeutic activity when they're not able to recall it. But you're going to keep them safe, and that can last for varying amounts of time. That can also be influenced by medication that's given when traumas occur. That can do, like pain meds can affect that. And so when you're looking back and assessing that, it will be something that you probably will have to ask family members, like at what point did they start recalling the daily events? Were they able to recall a conversation that, you know, and retain that and move forward? When you're looking at someone's chart, I don't know how many of you all review records. I do so very often in my job. But you're going to look for the Coma Scale over time. If you're looking at hospitalization records, you want to see how quickly they progressed on that Coma Scale. You're going to look and see if they were positive for AOC, positive for LOC, positive for PTA, and note the duration. And then most of the time, moderate to severe injuries will show evidence of structural damage to the brain, whereas when you have an individual with a mild TBI, it doesn't always show damage. All right, this slide, when we talk about the course of treatment, I ran a brain injury program, so I can talk a bit about that, but when a brain injury occurs, you immediately get acute care, whether that's on the scene, to the hospital to be evaluated, ICU, and then depending on severity, you may be further hospitalized in an acute inpatient setting until you kind of are ready to move toward inpatient rehab. I know here in town it's not Cardinal Hill anymore. I forgot the name of it, but it is a acute setting where you get intense care prior to moving out into the community. And the community can be back home or rehabilitation programs. And there's some across the state. One of the things that the state of Kentucky has is a brain injury waiver, but it does have a long wait list. So I'm looking at mild TBI diagnostic criteria. At least one of the following needs to be present. Period of loss of consciousness, a loss of memory of events before or after accident, any alteration in mental state. There may be focal neurologic damage, not necessarily. It doesn't have to be present at all. Typically it's not, but sometimes there is. So what you're going to see is positive loss of consciousness that is less than 30 minutes. The GCS is going to be Sorry. We're going to pause for a minute. That's okay.
I got him.
You got them. All right. So the GCS is 13 to 15 after 30 minutes of the event. So you may be just lower, not able to follow commands, but it doesn't last very long, so 30 minutes. Positive PTA for less than 24 hours, and positive AOC for less than or equal to 24 hours. So, I mean, points to remember with a mild TBI. Patients typically recover within 1 to 2 weeks fully without noticeable symptoms. So they return to baseline fairly quickly. They present with cognitive symptoms, slower processing speed, poor attention and focus, but that gradually improves over time. There are some complicated mild TBIs that we kind of talk about, recurring exposure. You didn't have a full time to recover from the initial mild TBI or concussion, and then you're exposed to another event. That does complicate factors. And so what we're seeing is that 6 months post, the outcomes are similar to a moderate TBI. So almost full functioning, but with some impairments. But 80% of people who show signs of mild TBI are not permanent. These are not permanent damage, and they do recover. So what I like about this chart, it shows symptoms that are occurring and reported most of the time when a mild TBI occurs. We're going to refer back to this when we're talking about PTSD in particular, because there's some overlapping symptoms, and we'll need to talk about that. I also like the fact that it gives a comparison to the general population. So when a person experiences a mild TBI, the majority of the patients report poor concentration, followed by irritability, tired, depression, memory problems, and that has their percentage of occurrence. But if you look at the general population, that's at a much lower rate. So you can see the effects. And then the nice thing about the base rate, it shows the percentage that it's an increase, which is pretty significant. So it's when the mild TBI occurs, there are some significant impairments, but those get better over time. Just keep that in mind. And if they don't get better over time, you have to start assessing what is causing the impairment. And it's likely associated with psychosocial stressors, some type of mental health condition or sleep disorders or something like that. So. All right, so now we're going to go into symptoms of moderate to severe TBI. These have more impairments, and they last for a greater amount of time, and they last for, they don't ever typically recover to the levels they were functioning at prior. So the cognitive sequelae includes attention and concentration problems. So a person's not able to attend to tasks at hand. They get distracted by someone walking in a room, or the color of someone's hair, or that someone isn't where they should be. I have a patient in particular that struggles with this, and he'll have a moment where someone walks into the clinic and he thinks they're creepy, and he might say that out loud. So you also have some impulsivity there. He gets distracted, but then he actually says some things. Memory is impaired as well, and learning. So we're not just talking about memories from childhood and forgetting those things. We're talking about when presented with new information, the ability to take that information in and recall it at a later time can show impairments. Or when presented with a list, to take that information in, we call that working memory, and then spit that back out to us, that's impaired as well. So anyway, the other thing is executive control dysfunction. That's more what I talk about, the ability to plan, organize, and sequencing. You know, the basic task of putting on clothing. Your shirt may be backwards. You may not get it on. You may have to prompt them to put their clothing on, or the steps in showering. We wet our hair before we put shampoo in it. Those steps and those basic prompts. There's also some communication problems, and that can be due to like word finding. There can be some expressive and receptive aphasia. Either, you know, expressive things are kind of messed up when they come out. They don't sound like they should, or they don't understand what to take in the information accurately. You know, when you think about how all these deficits, and then you have a closed TBI, that person will appear without any wound and or disability. So, you know, until you start having a conversation with them, you won't recognize that disability. And I think that's important when we're talking about being out in public. For individuals that struggle with communication, we always recommend carrying a card so you can explain, or just to show, because we want to increase independence. And so if they just need a card to say, here, I'm having trouble understanding you. The downside, the other thing in terms of cognitive deficits, is that sometimes individuals with a moderate to severe TBI may not recognize their deficits. And I think, you know, in treatment, that's one of the most complicated areas, is that they're not recognizing things they need to work on. So challenging individuals when you notice the impairment is very important. This leads me into emotional and behavioral problems. One of the things, there's an interplay between cognitive and emotional behavioral problems. You know, you may have increased distraction, poor concentration, problems forming memories or remembering things, and that leads to irritability, anger, acting out, poor, you know, impulse control and things like that, and emotional dysregulation. Or you could have emotional dysregulation, the anger, the irritability, and be distracted by those. So they work together in a lot of ways, but the emotional behavioral problems is what makes it a problem in receiving services, because individuals with extreme behavioral outbursts are hard to place in a community. You want to get them work experience, you want them to be involved in the community, but they're struggling with these deficits. What I will say, when you have a moderate to severe TBI, one of the greatest benefits is getting a baseline neuropsych eval, so it can outline those deficits and be able to target areas to work on within a team. And for a moderate to severe TBI, you need a team of folks. You need a multidisciplinary team that consists of, a psychologist, a speech therapist, an OT, a physical therapist, a nurse, anybody that you can think of, a case manager. I know in the past we've had supportive employment with folks we've served. So that will get you a baseline immediately, as soon as possible, where they're able to complete a neuropsych eval. And then you would repeat testing. I know our neuropsychologist recommends 6 months to a year post, that you see how they're doing, because most of the gains that are going to occur is within the first year after injury. Again, one of the things I will say, biggest challenges in working with TBI is the awareness of deficits. So just keep that in mind. I'm not going to go into medical complications, but this makes things more complicated when we talk about adjustment and things like that. Seizures, spasticity, neuroendocrine dysfunction, typically that's diabetes insipidus, hydrocephalus, I'm going to butcher that, heterotopic ossification, urinary bowel incontinence, headaches, and pain. What I will say though, when you're functioning on a normal day-to-day, then you have a TBI, and then you are faced with not only the cognitive challenges, the emotional challenges, and then you have physical challenges, there's definitely some grief, adjustment, and desire to isolate yourself. You're going to functioning every day till all of a sudden that you're having trouble with bowel and bladder, or you're having seizures, or you can't write without shaking. So there's difficulty in that, and that's something I work with patients on, is kind of adjusting to those deficits and being able to accept, grieve, and move forward and getting back into the community and getting involved. I mean, that's important to be involved in the community, working or part of organizations. So this is hypothetical recovery paths of cognitive functioning. What this chart shows is that when a mild TBI occurs, you get back to functioning pre-injury. And then you have moderate TBI that over post-year, you don't get all the way back up to pre-injury functioning, but you're close. Whereas severe TBI, you're going to have to deal with some deficits, which is very difficult for someone to have to deal with that lifelong. You notice that there's sharp gains within the first year of treatment, and that's when most of the recovery does happen. So it's really good to start getting services quickly and intense treatment at that, because that's when most of the progress is going to happen. And that doesn't always happen. Now, we're starting to see research where recovery doesn't stop at a year. Previously there was it was suggested that recovery stopped after a year. That's not the case. We do see patients who have made gains 5 years post, but it's not as quick and noticeable. In the beginning, it's highly noticeable of those gains. So for a patient's perspective, if you have a severe TBI and you're making big gains across the first year, and then 5 years later, small gains, that can be very depressing. And from a psychologist standpoint, that has to be addressed. and that's where you may see some of the depression and anxiety, as well as substance abuse, because impaired impulsivity, poor ability to cope. So you may see people abusing drugs and alcohol at that time as well. So, which complicates things because you have a brain injury mixed with alcohol and drugs. It doesn't help for recovery.